everybody. Welcome to iCubed number 41. 41 already. Okay, so thank you everybody for following and watching all these months. I appreciate your support. Today, I have a new guest, one of our new partners. I love this guy. I really do. And he's freshly out of residency. So welcome to iCubed, Chad.
Good to be here.
All right.
To be invited.
All right, very good. So Chad just joined us last summer. Do you want to introduce yourself, Dr. Bunker?
Yeah, I'm Chad Bunker. Just graduated residency in July from Desert Regional Medical Center. It's in Palm Springs, California. And just starting in my hometown hospital in Mesa, Arizona. So I'm excited to join the group back at my hometown.
That's great. Yeah, it's wonderful to have you with us, Chad. It's been really a pleasure to work with you these multiple months since last summer. All right, so I snagged Chad because I want to talk to him about a couple cases that unfortunately very common, and that we should talk about the way we think through these cases. So I'm going to tell you, Chad, about two cases. They're not hard to figure out what they are, but case number one, she's 21-year-old. She comes into the emergency department by POV, private vehicle. She comes in because she's been having severe abdominal pain. It was of abrupt onset. About 90 minutes before she came to us, she wasn't vomiting. She was not having any diarrhea. So I go into the room, and she's a thin young lady. She's very polite, awake. She's alert, very pleasant, but she's pale. She's in a lot of pain, you can tell, kind of doubled over, lying on the bed. She's got shallow, painful breathing. You can tell that just looking at it, right? So on the monitor, her blood pressure is 80/50. And her heart rate's 88, not tachycardic. Respirations are 19, SATs are 100%. That's fine. So quick exam on this lady, very firm, very much rebound, guarding diffusely, very, very tender. So, I chat with her a little bit. Her last period was about 6 weeks ago. She says she uses condoms. She's never been pregnant before, no history of STDs or any kind of gynecologic issues at all. And this pain is new. She's never had anything like this. And then she says, also, my shoulders really hurt. All right, so we're going to park that case right on the side, okay?
Yeah.
Case number two. All right, this is a few years ago. This young lady, relatively young lady, 41-year-old, the story we got from medics was that she was in the bathroom and she passed out while she was in the bathroom, right? She hit her head against the toilet, and she was found by the medics to be hypotensive. Blood pressure was in the 80s. So we're talking, and she tells me that she had a positive pregnancy test a couple of weeks before she came in 2 weeks ago. She's G7P3033, right? So 3 miscarriages, 3 live births. Her last menstrual cycle was about 6 weeks ago. She's been having some left lower quadrant pain, for a few days. It didn't really bother her very much, but it got really worse today before she came in. Mm-hmm. So on her monitor, blood pressure is 85/52, heart rate is 70, respirations are 17, and her SATs are 97. Again, do a quick exam on her, focused exam. She's kind of a heavy-set lady, very lucid, alert, talking to me. Belly is moderately tender, and she's guarding with rebound. So now what, Chad?
Yeah, so both of these are good. They're both sick patients.
Yeah.
But so I mean, the differential, includes the concern for ovarian torsion,
of course, yeah,
ectopic pregnancy, and possibly ruptured, ectopic in maybe even both of them, which these are sick patients.
So if you had these ladies, I mean, what would be the first kind of set of things you would do or think of or tell the nurse to do right away?
Yeah, I mean, I think it is important that you communicate real clearly with the nurses. So you have to be very clear about this patient needs 2 large bore IVs. They need to be placed on the monitor. This patient needs fluids immediately. Almost kind of like tell the nurse, hey, we're going to treat this as like a trauma patient. Try to be that focused on this patient. So, I mean, she's hypotensive. She needs fluids. We need to get, a rainbow of labs.
Yeah.
We need to get a type and cross. She's most likely going to need blood, especially if it's ruptured at that point.
Yeah.
And I think that you need to involve either OB or gynecology very early in these cases, because the only fix a lot of times is the OR to help them. We can kind of stabilize them, but they need to be out of the ER, as quickly as possible. If you're astute at bedside ultrasound, I think this is when it really comes into play to have it right at the bedside and look for blood in the abdomen.
Yeah, excellent. So what did I do immediately for this patient as well as the other one, actually, in addition to what I was telling the nurses to do?
Yes. Oh, yeah. Lots of blood.
Yeah, I put my probe down and I was like, I almost gasped, but at the same time I wasn't shocked.
Yeah, her exam was telling you this too.
Here's another view. Wow. This is, I went over to the left side. And then I did a suprapubic view.
Suprapubic. Oh yeah, blood all around.
So what did I do after the POCUS?
Yes.
Wait a minute. Okay, mind you, I had no labs. All I had was a bedside H&H, okay? I didn't have a pregnancy test. They only had the HMP, the POCUS, and my H&H at the bedside, right? So the reason we had to be very aggressive in getting all the resources for a patient like this is the patient was hypotensive, right? And you saw enough, you had enough information to know that this lady is shocky or peri-shocky, right? Yeah. So fortunately, the gynecologist on call, I've known him since forever ago, right? When I started over there. And I think he trusts me. But he was like, okay, well, I'm making my way and I'm going to call the OR and whatever, right? And so bedside H&H was 11.9 in the emergency department. And what's funny is, not funny, but what's interesting is that, we're gathering the staff, getting everybody, taking this patient to the OR. And as the patient is being wheeled out, literally or out of bed 44, the pregnancy test comes back positive.
Just to reaffirm that you made the right decision.
Yeah, just to confirm what we all thought was going on, right? So then, the OR, just pre-op. This is pre-op, right? Oh, her hemoglobin is 8.8. 21-year-old. So I looked at the chart, and she actually became hypotensive there in the pre-op. Her blood pressure dropped into the 60s. So they immediately ordered the non-typed emergency blood, and they started the transfusion right away. The gynecologist, OB, did laparoscopic surgery showing massive hemoperitoneum all over, right? He thought there was 2 liters of blood in there, and it looked like it, right? I mean, with the ultrasound.
Yeah, all quadrants, yeah.
Yeah. So unfortunately, she had a ectopic in the right tube, and he performed a right salpingectomy, but she did so well. I mean, she did very well, and she was discharged the following day. All right, what about case number 2?
Oh, just as good.
All right, so this is a 41-year-old, right?
Oh, yeah.
All right, so once again, I mean, this lady, the 41-year-old syncope with a known positive pregnancy, we had no labs at the bedside. I did order a bedside H&H. There was no confirmation of her pregnancy status, although we trust her, of course.
Yeah, just her word.
She only had the POCUS and the FAST exam and an H&P, right? Well, once again, these patients are shocky, perishocky. And just like you said, Chad, they kind of really have to be treated like a bad trauma patient, right? And everything's got to be expedited. So call the gynae, and the gynae took her to the OR. In this patient's case, in the ER, her hemoglobin is 11.5. So then the next day, they got the H&H, and it was 8.3. This one did not get transfused. Laparoscopic surgery showed large hemoperitoneum, but the gynecologist estimated there was only really about 300 cc's of blood loss in her case, I guess. They did a left salpingectomy. That's where the ectopic was, and then did a right tubal ligation because she had verbalized before the OR that she wanted to have tubal ligation. And then she was discharged the next day. Did very well.
Both did very well.
So, folks, every month we have 2 learning focuses. First one, obviously, ectopic pregnancy. So this is just a little image of where the common ectopic pregnancy locations are. So most of them, the 95%, more than 95%, is in the fallopian tube, 70% in the ampulla, 12% in the isthmus, 11% in fimbria, and 2.4% in cornua. And so these are just different parts of the fallopian tube is all. The other 5% of ectopic pregnancies would be very unusual. They'd be in the abdominal cavity, maybe in the ovary, and maybe even in the cervix. I even read somewhere there's a very small percentage that occur in the C-section scar.
Oh, wow.
Yeah. But anyway, so there's an extremely rare ectopic, which I learned about early in my career. I've never seen all these years, but it's heterotopic pregnancies, meaning you've got an intrauterine pregnancy and then you've got an ectopic at the same time. That is
that's no manner of luck at all.
Right. So then this is a table from Medscape that I looked at for the risk factors of ectopic pregnancy. So these are just rough ideas so that when you're talking to the patient, you have some level of suspicion, high or low. The high risk factors on top here, it looks like the most high risk would be tubal surgery in the past. Tubal ligation is a very high risk. Previous ectopic pregnancies, in utero exposure to diethyl sylvestrol. It's a artificial estrogen, and so it resulted in infertility of the women or females that were born to women who took this medication. And it also resulted in increased ectopics in the women that were born from women who took this medicine. Also, in addition, there are other high-risk factors such as IUD usage increases your chance of having ectopic, having tubal pathology, having assisted reproduction, meaning IVF. Then there's moderate risk factors such as infertility to begin with. There's history of previous genital infections, STDs, then multiple sexual partners. Then there are some low risk factors for ectopics, previous pelvic infection. I suppose that means non-STD type pelvic infections. If you're a smoker, you have more risk for ectopic. Vaginal douching increases your ectopic pregnancy risk. And then if you've had sexual intercourse before age 18, you have an slight increased risk for ectopic. All right, so signs and symptoms, most commonly vaginal bleeding and or abdominal pain, and that comes every month. In fact, most women have this every month. All right, anyway. So signs and symptoms of an ectopic pregnancy, the most common symptom and sign and symptom is vaginal bleeding and or abdominal pain. There's also, and this is terrifying, but there's also painless vaginal bleeding for patients that have ectopic. They come in and have hemorrhagic shock, as we've seen. They come in with syncope. They can have abdominal or pelvic tenderness on exam, and they have sometimes an adnexal mass. But all of those are really non-specific and not real sensitive. But the diagnosis of ectopic pregnancy has to be a combination of the serum HCG to confirm your pregnancy status, and then a transvaginal ultrasound. But sort of an overall approach towards an ectopic, this is from UpToDate.com. Number one, obviously, you want to confirm your pregnancy status. You want to evaluate for hemodynamic stability. You want to determine if this is an extra uterine pregnancy, and if it is, where it is, all right, if possible. Obviously, you have to determine if the patient has ruptured, if the patient's ectopic has ruptured versus intact.
Yeah.
And then further testing, like you said, Chad, the labs and all that, to guide your management, right? So that's just kind of overall management strategy.
I think that's what you did so well in both these cases is, it's so important to be proficient enough with ultrasound, because you won't have time for a formal ultrasound. Right. You won't have time to kind of wait for that. So getting good enough with ultrasound so that you feel confident to put it on the abdomen, take a look. Most likely you saved, the life of that first one for sure. You don't have much time, when it comes to these bad ruptures.
All right, so learning focus number 2. Focus!
There you go. I knew that was coming.
But 5 or 6 years ago, Dr. Teresa Wu, who is an icon in medical and emergency medical education and simulation instruction and bedside ultrasound instruction. Dr. Wu conducts ultrasound courses all the time, right? So a handful of us at Baywood went ahead and took that course, and I became immediately struck and enamored by this technology. I kind of consider myself a POCUS evangelist. So,
good word.
I just want to quickly go through this. Reasons to use bedside ultrasound, POCUS, right, gives you a quick yes or no. It's a rapid binary test that gives you, is she ruptured? Is there free fluid? Is there a large aorta? Is there a pericardial effusion, right? Is there a pneumothorax? So it gives you yes or no's very quickly within minutes, as opposed to 30 minutes or an hour. And that, for some patients, make a life-saving decision for them. Number 2, it does improve safety of procedures, such as if you're trying to put a line in, femoral line, subclavian even, then it improves overall efficiency going through the ER. If you can quickly make a diagnosis or work things out, you don't have as much lag between evaluations, right? It does improve patient satisfaction. There's multiple times where I would do a quick baby ultrasound or something just to reassure the mom that the heartbeat is okay, is within acceptable limits. To me, this technology is an extension of a bedside exam, right? I can touch the surface of a patient, but looking beyond where my fingers can touch is so, so helpful. So to me, I love the POCUS because of that. It is a non-invasive exam, which is a good selling point. It is not an ionizing procedure, meaning no ionizing radiation. And, with everybody being very conscientious about overexposure to, CAT scans and stuff, I think this is an excellent reason to use a bedside ultrasound. And then theoretically, you can repeat the bedside ultrasound fast exam, for instance, if you have a patient going to OBS or something, and you can certainly theoretically follow them up that way. And it is cost effective once you've sort of put down the money for the equipment, right?
Yeah. And I do think that just the point on the improves patient satisfaction, that's not to be understated. They really do. They feel very taken care of. They feel that you're trying your best to find, these diagnoses. And my ultrasound coordinator, Grant Nelson, he always, kind of preached that these patients, they do love it. They see that you're trying, even if you're going to send them for a formal, they see that you're trying to figure out what's going on, and they appreciate it.
Yeah, I think that's a great perspective. All right, so as much as I love POCUS and evangelize about it, there's downfalls, and it's limited. You have to remember this technology of ultrasound. It's going to be less accurate in obese patients. You just can't get through all that soft tissue. It is less accurate in patients that have ileus or if they have cutaneous emphysema. The ultrasounds don't transmit very well. And you cannot differentiate the type of fluid. Is it blood? Is it ascites? Is it water? Whatever. Is it pus, right? Mm-hmm. It is very operator dependent, obviously, because it depends on how good you are at the skill. And then ultimately it is machine dependent. We're fortunate that a few years ago, Dr. Zosky was able to secure a really nice machine for us. We had an older one before that was adequate, but this new one is great.
Yeah.
So, Chad, thank you so much for joining me and trying to teach along with me about this pretty bad problem.
Those are great cases. Yeah, that's a great learning, because I don't think you can ever act quick enough with these patients. So.
Yeah, I was like, I'm so glad I could do a bedside ultrasound. I didn't even order a formal one on either of them.
No, yeah. I mean, if you're proficient enough with it, I mean, you don't even need labs. You just a bedside ultrasound and call the OB.
All right, folks, that is episode 41. 2 very, very sick ruptured ectopics that we managed to get through very quickly to the OR where their lives were saved. So I hope you learned something about these kind of cases, to be very suspicious and very quick on getting the staff together and making sure to resuscitate them at the same time as you're trying to get the right staff, like the gynecologist and OB. But thank you, Chad, for joining me.
Great cases. You're the best, Alice. Thanks.
All right. So then, thank you, everyone. I hope you learned something this time, and I will see you next month. I hope you are all corona-free right now. Bye, everybody. Bye, Chad.
Bye.